I will present the results of two recent trials which has been presented during the last meeting of the American Heart Association in Chicago at the beginning of November. These trials are REDUCE and VITAL. Data of VITAL have been previously shown, but my talk would focus on the relative effects of placebo versus Icosapent Ethyl on non-HDL cholesterol, CRP, and cardiovascular risk. The goal is not to answer the question, but to ask questions. This study has shown that the drug was effective to reduce the cardiovascular risk. The key inclusion criteria have been previously shown, and the biomarkers are very interesting. We can see that the triglyceride decreased by 36 milligrams per deciliter in the IE group and increased by 5 milligrams per deciliter in the placebo group. LDL cholesterol increased by 3 milligrams in the IE group, but increased by 8 milligrams per deciliter in the placebo group. And for non-HDL cholesterol, the decrease was 5 milligrams in the IE group and 11 milligrams increase in the placebo group. For CRP, there was a decrease of 0.4 milligrams in the IE group and an increase of 0.7 milligrams in the placebo group. And the relative cardiovascular risk reduction was about 25%. So if we consider the non-HDL cholesterol to take into account VLDL, IDL, LDL, and the remnant lipoprotein, the decrease was 70 milligrams per deciliter between the treatment group and placebo group. This is a 31% decrease. But as there is an increase in non-HDL cholesterol in the placebo group, 9% of the decrease could be due to an increase induced by placebo, and only 4% to the decrease induced by EP. This means that 70% of the effect could be due to the increase induced by placebo, and only 30% due to the drug. It has been reported that a decrease of 1% in non-HDL cholesterol induced a 1% reduction in the cardiovascular risk. This means that 13% of the reduction could be due to non-HDL cholesterol. And this means that 9% of the decrease could be due to the increase in the placebo group, 4% in the decrease in the IE group. Data concerning cardiovascular risk, cardiovascular death plus non-fatal myocardial infarction show a reduction of the cardiovascular risk of 22%. 9 on this 22% could be due to the increase of non-HDL in the placebo group, 4% to the decrease on non-HDL in the placebo group, and 9% to the non-lipidic effect of the drug. And the total effect of the drug will be 13% out the 22% of the cardiovascular reduction risk. So the risk reduction will be due to Icosapent Ethyl for 60% and for 40% for the placebo. So if we are interested on another biomarker, CRP, it is interesting to remember the Jupiter study. The design of this study was to test the effect of rosuvastatin in a population with a low LDL cholesterol but a high CRP level. In this study, CRP decreased by 0.8 milligrams in the placebo group, 2 milligrams in the rosuvastatin group, and the decrease was 1.2 milligrams between placebo and rosuvastatin. In REDUCE, there was an increase of 0.7 milligrams in the placebo and a decrease of 0.4 milligrams in the group treated with IP. The differences are similar between Jupiter and REDUCE, but in REDUCE, 64% of the effect are due to an increase in the placebo group and 36% to an effect due to the drug. The two studies, comparison of the two studies, the decrease in CRP were similar. The decrease in non-HDL cholesterol was very important in biorostatin and less with the icosapent drug. And the cardiovascular risk was very more important, 47% versus 22% between Jupiter and Reduced. So, in summary, as the increase, the decrease in non-HDL cholesterol is due for 70% to placebo, and the decrease in CRP due to 64% to placebo, the question is the cardiovascular reduction risk observed due to placebo or to the drug? And I have no answer to this question, but it's very strange. Another study was presented at the American Heart Association, the effect of marine fatty acid on prevention in cardiovascular disease and cancer. The conclusion was supplementation with omega-3 fatty acid did not result in a lower incidence of major cardiovascular events or cancer in placebo. There was only one positive effect, was for the number of total myocardial infarction, which was reduced by omega-3 fatty acid, but the major cardiovascular events were similar between treatment and placebo. So, in conclusion, in reducing icosapent ethyl could have induced less than 40% of the observed decrease in non-HDL cholesterol and in CRP, while the apparent residual 60 decrease could have been due to the capacity of placebo to increase non-HDL and CRP. In that condition, most of the apparent cardiovascular risk reduction may have been due to the capacity of placebo to increase this risk, and not to the capacity of icosapent ethyl to decrease this risk. And in vital, supplementation with fatty acid, NO3 fatty acid, and omega-3 fatty acid, sorry, did not result in a lower incidence of major cardiovascular events or cancer. So this data need to be further analyzed with a full specialist of statistics. Thank you.
Thank you.